Today we'll be demonstrating a case of an UroLift for I think a grade 1 bar grade 2 prostate in an elderly gentleman with a high cardiac risk. And to start with, we always do a cystoscopy to understand what is the size of the prostate and how much length is the size of the prostatic urethra. So we are doing a cystoscopy, and okay, that is the prostate. Let me empty the bladder first. Just emptying the bladder on that. It's always necessary to understand the size of the prostate. Well, we know some part of it in an ultrasound preoperatively done. At present, we are looking at a smaller size gland only, and this gland was been reported as a 25 or a 28 cc gland. And let us do a cystoscopy and understand how big is the prostate and what is the bulge of the prostate into the urethra, and how much is the length of the prostatic urethra. The length of the prostatic urethra is very important when you are planning a UroLift procedure because of some reasons which I will explain just now. So this is the bladder, which is completely fairly trabeculated bladder, and then this is the prostatic urethra, and this is the gland size of the thing. There is a left lobe which is a little enlarged. Can I have a focus? Okay, that's an autofocus on. This is a verumontanum. This is a lobe of the prostate on the right side, and then on the left side there is no median lobe. So it's a grade 1 gland only, as we suspect. So if I need to see the length of the prostatic urethra, I'll make a mark onto the resectoscope when I am there near the bladder neck. So this is the bladder neck marking when compared to cystoscope, and I get back myself up to the verumontanum. So this is a verumontanum. So it's somewhere around 2 centimeter size, 2 centimeter or 2.5 centimeters. Usually many cystoscopes have got a marking onto it, so that will be easy for them to understand. Why that is necessary? Because when we do a UroLift procedure and lift this procedure, the arc of rotation of the needle which goes across the prostate usually will have 1.5 centimeters 1.5 centimeters, 1.2 centimeters an arc. So whenever we need to do a UroLift, you need to be at least withdrawn 1.5 centimeters from the bladder neck area. So it is, in this case, it is just in front of the verumontanum, 1.5 centimeters somewhere here. Otherwise, what will happen? The needle will pass through the bladder mucosa at this point and come out into the prostate. So that is an exposure of the thread which comes across into the bladder, which should be avoided. So that is the reason why length of the prostatic urethra is measured. So it's a grade 1 prostate. It has got a more than 1.5 centimeters or nearing 2 centimeters urethra. So I can position the UroLift entry point at this point to press this lobe laterally, and then place the UroLift into it. So I finished my cystoscopy. I saw the bladder. There's nothing wrong in the bladder. So I'll go ahead with the procedure. So we should understand that there is a 2.5 centimeters of length or a 2 centimeter length, which is idealistically should be there below the bladder neck in front of the verumontanum. So our UroLift, whatever string which we are going to keep it, should have an entry point 1.5 centimeters away from the bladder neck, so that the arc goes through the prostate, not through the bladder. So exposure of the sting into the bladder is detrimental, and it causes irritation and stone formation also. In some instances, we have done 1 or 2 cases done outside in US wherein we saw the clip of the thing placed in the bladder, and in one case the sting was exposed through the bladder. So the mistake happens because of that reason. So we emptied the bladder now. So we will go with a cystoscope given by the company, which will enable us to deploy the UroLift. The cystoscope given by the company has a 20 sheath, and it has got a longer bridge with a longer telescope and a thinner telescope of 2.5 mm, I think. Yeah, 2.9 mm. So this bridge is taken out and kept with the UroLift instrument there, so that we can have the same vision here. So this is how the construction of the cystoscope is there when you want to deploy an UroLift. Okay, so we're going to do the procedure now with this. I have an initial inspection of the whole thing at present moment on a cystoscope. So I know that it's a grade 1 prostate, and I'm going to use deploying the UroLift on both sides. No. So I know that it was a yes. It was the length of the prosthetic urethra is already measured. I just want to clean it because there is some amount of jelly which was there. Let me have a proper. Okay, that's a bladder. That's a prosthetic urethra. Okay, table up. So that's a verumontanum, and this is the lobe here. Right, head end down. Right. I usually keep the best way to position your cystoscope is to understand when the urethra, prosthetic urethra is flat for you. So head end down a little more. So the prosthetic urethra should be flat. Right, still. Right. So that the cystoscope also is flat to the ground. So that's how the distribution has to happen for a proper deployment, especially in a thinner prostates. Otherwise, the thing what can happen is that they end up in having a bone hit. That means the needle gets deployed, but it hits the bone on the lateral aspect of the prostate, especially in a smaller prostate. That is not usually common in a bigger prostate, but in a smaller prostate it happens. Can you lift the table, please? Okay, I am trying to empty the bladder completely so that I can have adequate amount of vision. Okay. Right. Come down. So this is a UroLift applicator. It's a loaded pin inside, loaded sting and needle which is inside. You can be used only for one application. If I need to use another sting, this has to be replaced. So this will have the telescope inside and it is fixed on this side. So there are three elements of the UroLift. One is the handle, and this is the way it gets placed into the sheath. And then when we have two functions. Number one is compression of the prostate and deployment of the needle and cutting the UroLift, the sting which goes across the prostate, and then having a clip onto it. So there are three functions. The first function is going to be unlocking the use of the handle. So this is a locked. Whatever I do, it doesn't move. So the unlocking is happened by this, keeping this button on this side. And number two, by pressing this gray button, that's first thing is it is going to deploy the needle across the prostate. By pressing the second button, we are pulling the sting across, giving a compression, and by pressing this knob here, we are going to deploy the clip onto the other side, on the prosthetic urethral side, and cutting the sting across. So these are three functions which will automatically happen one by one. So let us look into each function when it is being done. So idea is to identify the location at which the needle is going to penetrate the prostate. Number two, compressing the prostate. Number three, pulling the sting into the instrument, which happens, and then cutting the sting with a deployment of a clip on the other side, on this side of the prostate. So all these functions have to happen. So let us keep the instrument inside. So whenever we come across, so this is the thing, and we saline on. Okay, table down please. Still. Okay, this is the verumontanum and this is the bladder neck, and we said 1.5 centimeters inside the below the level of bladder neck. So we need to turn the thing towards the angle at which you are going to place, and this is the verumontanum, and the position is coming just in front of the verumontanum. So saline on. So we want to deploy the needle will go. This is going to, we are going to compress the prostate on this direction. I don't want to do too much of a compression because this prostate is small. The chance of bone hit is very high. If you want to do, we unlock the instrument. We're keeping the thing a little flatter, yes, flatter, and then we are going to, yes, Now we have deployed the needle. We are giving a little compression onto the prostate and then pulling both the things inside. So you can see the sting inside, the blue color sting. And we are going to press and then move forward towards the bladder neck. At one point of the time, you will see a half illuminated needle-like thing inside the prostate, inside the sting. You can see that. You can see that now. You see that now. That whitish area halfway through the bleeding. So you're going to cut it and it gets deployed. So you can see that the whole prostate is got compressed and deployed, and that's a clip which is there. And you can see that that part of the prostate is completely opened up on the left side. And now we are going to look for the right side. Got a little higher, I presume. I could have stayed a little lower. Give me one more. The best way to know whether you have gone through the bladder or not is looking for any bleeding inside the hematuria in the bladder. If there is no hematuria, that's unlikely. It's absolutely clear urine. It's very unlikely that you have entered into the sting has gone through the bladder. So we are inside the bladder now. We are going to go the other way around. Yes. We are going to identify the bladder neck. This is the bladder neck. We came 1.5 centimeters back. This is 1.5 centimeters away. And we are just in front of the verumontanum. We are pressing with the left lobe. We are doing it with the left hand now. And then I am going to unlock it, deploy it, yes, I can see the whitish with the sting inside. I am proceeding a little ahead. I can see a white line inside that sting, halfway, yes, halfway, and now I deploy it. Yes, on both sides it is deployed. Now let us have a look at the prostatic urethra, how it looks now. There was a bone hit, but what happened is when I moved the instrument a little this side, it got salvaged and it came inside. So that's the reason why there was a movement of the girdle or pelvic girdle of this patient. But what happened is when I moved the instrument inside into the urethra, it came out of the bone and it got salvaged. Now I have done a cystoscopy. This is a cystoscopy which is there, and this is the bladder neck, and this is one sting which is got deployed here, compress the prostate on the other side, and this is one sting which is deployed here and compress the prostate on the other side. This is somewhere here, yes. So the bladder neck is quite wide open now. I don't think anything else should be necessary. Majority of the times this compression itself will lead to some sort of an apoptosis and leading to better flow rates afterwards. So there is no bladder neck. There is a wide open bladder neck, and there is a compression of the prostate. Shall I put one more here? That's what I am looking at. The pendulum camera is always good. But anyway, for demonstration, the pendulum camera is ideal thing, but for demonstration this is better because majority of the units do have this sort of a camera only. So we have a bladder neck, and now we are coming down. I am looking at one more sting being placed at the level of just above the verumontanum on this gland which is seen compressing in this area on the right side. Exactly just above the veru. So this is the verumontanum just above the veru. I am not compressing too much. It's not a very big gland. So I just need to deploy and then try to compress. I am just deploying, pressing this blue button that deploys the needle. Yes. And then I am compressing both the buttons and compressing the prostate. It exposes the thread inside, the sting inside, and I am pushing a little. Then you will see the needle. Yes, it is come, and now we are deploying it. It has been cut and deployed. So let us look into how does it look like at the end of 3 stings in this patient. The ideal thing is going to be a pendulum camera so that you don't need to hold this camera. It shows the same vision all the time. But majority of the units do have the camera which gets fixed like this. So we are just demonstrating the same thing here. So this is the verumontanum. Now the prostatic urethra is wide open. There is a compression of the gland here, there is one more here and one more here, 2, and then one more here, one more on this side. So this is a wider open bladder neck, and that should be good enough. I leave a catheter for 1 day and take it out the next day. There is some amount of edema. Majority of these patients are going to be kept on an alpha blockers for a period of 1 week, and usually we expect a best symptomatic improvement at the end of 2 months. 2 weeks rather. So that should be enough. Get a 60 number Foley's catheter.